Nice. I think if it's okay with you, Matthew, I think I'll do my introduction and we'll get going. I know folks will join us as we continue. I think everyone knows, but I'm Nancy Frank Wilson with the Minnesota Oral Health Coalition. We're very happy to see you today and happy that you could join us. This is something that I had many requests for, and I also wanted to ask Matthew to do this for us, so I appreciate it. Matthew Bergeron is our presenter today. He draws upon a unique blend of legislative, public policy, and health law experience to help clients navigate a broad variety of potential pitfalls related to regulatory compliance, licensing, and public program reimbursement. Matthew represents a broad variety of long-term care providers, including skilled nursing facilities, assisted living facilities, home care agencies, home and community-based service providers, and personal care assistant agencies. He works closely with both DHS and MDH to help providers navigate the complicated landscape of registration, licensing, provide enrollment, and regulatory compliance that surrounds long-term care providers. He leverages his strong relationships with Minnesota legislators and regulators to help clients develop, draft, and promote their legislative agendas. With particular focus on Medicaid providers, Matthew represents a variety of providers who focus on serving low-income and immigrant communities, including community health clinics, safety net dental clinics, substance abuse disorder, mental health, and other behavioral health providers. He advises on the potential impacts of public health program reforms, including the Minnesota Department of Human Services development of integrated partnerships. And many of our CAD providers look to Matthew as their expert and their support, and he's an excellent partner to the MOHC. So welcome and thank you, Matthew.
Thank you so much, Nancy, and good afternoon, everyone. It's always a pleasure to connect with you all. I've spent probably close to 8 years now working pretty closely with a variety of critical access dental providers in a number of capacities, both in a regulatory and in a legislative context. I'm happy to be here today to kind of talk through a little bit about what happened during the 2024 legislative session, the likelihood of all of that holding up going forward, and then what 2025 might look like, both via the election as well as the budget. So I'm going to share my screen and bring up some slides. Nancy's going to help me keep an eye on the chat, but if folks have questions, I'm happy to be interrupted or to answer them as we go, or to take them at the end, to the extent it can be as fruitful as possible to you all as the audience. I'm happy to go either way. So
wonderful, thanks.
And all right, here we go. So as Nancy said, I'm a regulatory transactional government relations attorney at Larkin Hoffman, and a lot of my practice centers on working with Medicaid providers in one form or fashion. Anytime the Department of Human Services or the PMAT plans are a primary payer, that tends to be where I spend most of my time. This is one of those things that when you work at a law firm, they make you put in any slide or presentation you're talking about. If you have specific questions, I'm happy to answer things here, but if there are things that are particularly important or impact your organization or which you may be relying on for some of your decision making, please feel free to either contact me or contact your counsel. This is intended to be a higher level educational presentation. So kind of three things I'll talk about a little bit. Probably maybe the first half or so will be the 2024 legislative session, some of the dental legislation that passed, some of the other things that were considered that are worth noting, and then a little bit of a commentary on some potential litigation and what it might mean for some of the things that we're talking about here. The next part is I'll talk a little bit about the 2024 election. Obviously, it's a presidential year, and we're all kind of aware of those ongoing dynamics. But there's a few. There were already some uniquenesses to the electoral landscape and the situation here in Minnesota, even prior to Governor Walz being nominated as the Democratic vice presidential nominee. That, however, has also complicated things and could set us up for a quite a unique start to session. We'll talk about that a little bit, as well as a little bit about the budget session coming up. So first and foremost, 2024 was not a budget year. So and with the legislature came in February with a one-time short-term surplus projected, but some structural budget issues in the next biennium, the one we're about to go into. And so there was a lot of discussion about restraint on spending. So a lot of the bigger reimbursement conversations were not really on the table in 2024. More of a policy or quote unquote. But in that there were kind of three. The other thing I should say is it was the first time in probably 6 years that both chambers put some substantive work into health professional licensing. That is just not something that had really been a priority or a focus in recent years. And so that meant there was an incredible backlog in proposals. So only a portion were able to be heard and advanced. But it does mean that the most of what kind of got done in impacting dental providers is kind of in that more health professional regulatory space. The first thing to talk about is the Dental Interstate Licensure Compact. For those who may not be super familiar with what a licensure compact looks like, is generally when you're licensed to practice a profession in a state, you're licensed to practice in that state. And if you want to be able to practice in another state, whether it's because you're going to split your time, or in a world of telehealth or teledentistry, where you may be able to provide professional services remotely from where the patient is, you need to be licensed in the state where the patient is and the state where you are. And so one of the things that we've seen in recent years, but particularly post-COVID, with the nationwide expansion of telehealth, as well as ongoing workforce issues in rural communities, is the use of licensure compacts. What this essentially means is if you apply for a compact privilege, you have to be licensed in the state that participates. All the states that are participating have agreed upon a certain set of baseline rules. And then if you apply to the compact, you are then able to practice in every state which has enrolled in the compact. And so one of the things that came out this last year, actually about a year and a half ago, it started in a couple of states in the 2023 legislative session, was a new interstate licensure compact for dentists and dental hygienists. And so Minnesota was one of the first states. You need 7 states to enroll in one of these for them to get up and going. Minnesota was one of those. And so we'll be kind of at the ground floor as the compact is put together. But what that means is that Minnesota licensed professionals will be able to practice in the other states that are participating. And so over the next couple of years, as more states potentially enroll, that will create more opportunities. But already there are border states that have enrolled and have created that. I think Iowa was one of the first states. So, kind of how I see this playing out is you've got the ability to, in a store and forward teledentistry model where you've got clinicians out in the field, either in a clinic or in a remote site, taking images, and then things need to be evaluated or diagnosed by a dentist remotely before their care can be ordered. That person would no longer necessarily need to be located. That dentist would no longer necessarily need to be located in Minnesota in order to be able to review those images, diagnose, and order a course of care. I think with an aging health professional population, this just creates a lot of flexibility, and it's something that I imagine over the next couple of years as the compact gets up and running, will help with some of those access issues a little bit. The second change was there was statutory language historically that had prohibited a specialty dentist, somebody who held themselves out as being a specialist, having been appropriately credentialed to do so, who also held a general dentist license from also practicing as a general dentist. Setting aside the original origin for that, one of the things I think we saw as some specialists transitioned into working less or moved towards some kind of partial retirement was the desire to continue to practicing in some form or fashion, whether it was volunteer or part-time doing general dentistry, which they were appropriately licensed to do, but because they had held themselves out as a specialist, were not able to do. So this was a minor change that I think is particularly impactful for folks where they may be able to provide some measure of care, maybe not in a full-time capacity anymore, but some measure of care as opposed to no care under the previous structure. And lastly, the bigger change was one of the things worth noting was a change to the dental assistant licensure by credential law. So previously a licensed dental assistant who was licensed in another state and sought to be licensed by credential in Minnesota had to have graduated from a dental assisted program accredited by the Commission on Dental Accreditation, and they had to be certified by the Dental Assisting National Board. Now it's an or. My understanding is that had been the case up until maybe a handful plus years ago. The statute changed and they reverted it back again. I think trying to eliminate barriers for people who are licensed as dental assistants in practicing in other states to become licensed as dental assistants here. I will note that once you're licensed in Minnesota, whether it's via licensure compact as a hygienist or a dentist, or by credential as a dental assistant, you're subject to all of the Minnesota Dental Practice Act and corresponding regulations and the oversight of the board. So like you're still operating under all of these same patient protection and public safety laws. Other changes of note, things that maybe weren't specifically targeting the practice of dentistry in the state, but that are worth noting. First one is a prospective prohibition of for-profit HMOs in Minnesota, effective January 1, 2025. DHS will not be able to contract with for-profit HMOs. This undoes a change that had historically been the case. I believe it was 2017 when the legislature amended the law to allow for-profits to come in and compete with the nonprofit providers. This is since kind of reverts back to that. I'll talk a little bit later, but this is one of the things that's subject to litigation going forward. But that has some potential impact on the role of managed care in dental conversations going forward. A second thing to note is the legislature directed MDH in consultation with others to provide recommendations and come back with a new health professional workforce advisory council. I think there's just a desire to have a new approach, a new and potentially comprehensive approach that brings in higher ed and Department of Health to look at health professional issues. It's worth noting in this space because dental professionals were expressly included in the list of professionals that would be kind of a part of the scope or charge of that new workforce advisory council, if and when it's ever set up. And then lastly, kind of from a more clinical operations standpoint, a year ago, October, the Minnesota Supreme Court ruled in a case involving fundraising by an entity covered under HIPAA in the Health Records Act, that the Health Records Act language authorizing uses of protected health information as authorized in law included all of the allowable uses under HIPAA. Historically, everyone had operated in the legal community, interpreted that as saying authorized under state law. That's essentially what the legislature then responded back and said, no, we intended the Health Records Act to be more strict than HIPAA. So the takeaway here is that if you didn't change what you were doing after the case in involving Children's Hospital in last of October, you don't have to do anything. It's a reversion. And I think most people saw this coming and probably didn't change their practices. But it does mean that there's been a little bit of conversation at the legislature in recent years about the relationship between the Health Records Act and HIPAA. And I think it kind of closes the door on I think it was a pretty clear signal that the legislature isn't particularly interested in a bipartisan manner of going towards loosening the Health Records Act the way maybe it had been asked to in a couple of years in the past. So while those aren't specifically dental related, those are all things that I think impact the organizations a lot of you all work with, the practice of dentistry in Minnesota, particularly as it relates to public health programs. I did want to note on a couple of things that did not pass in the 2024 session. There was a proposal that passed out of the House of Representatives that advanced out of committee, at least to start in the Senate, that would have converted Minnesota Care into a public option. This, I think, would have further expanded the number of people who accessed healthcare through one of the public programs. It would have created a sliding fee premium scale for individuals that currently make too much to access Minnesota Care in an attempt to move towards kind of a broader public option. It kind of received some pushback, frankly, from both sides of the political spectrum. On one side, there's concerns that the greater percent of the population that receives its health care through a public program with their generally low reimbursement rates, the more difficult it is for providers to continue providing care. The other critique of it was that it didn't go farther. Excuse me, that it didn't go far enough. The proposal actually stalled out in the Senate because a number of more progressive senators saw it as an incredibly expensive half measure to what they wanted to see as a universal healthcare model. I expect that to be a continued point of conversation going forward. But again, it would have some impact for those of you who serve either individuals on Minnesota Care or individuals who might otherwise avail themselves of Minnesota Care versus a more expensive private option. There were a couple of workforce development initiatives, a couple of grant proposals for funding for training programs that popped out there, including one $150,000 proposal for a dental assistant program at Summit Academy that actually advanced all the way into conference committee. None of these were passed into law, and I think, as we talked about in an earlier slide with health professionals work, there's an attempt to try to be a little bit more intentional or come up with a more cohesive plan as it relates to the higher ed system. But I would anticipate some of these things being talked about because there's a pretty universal recognition of the need to train more individuals, including in the dental industry. And lastly, something that I think would impact all of you providing public program care. There continues to be conversation and efforts to update the MA fee schedule to current cost data, what we might call a rebasing or a readjustment of that baseline reimbursement model for public programs, and add an inflationary factor so that there's some ongoing adjustments to reimbursement for public programs. Not being a budget year, that didn't advance this year, but we anticipate there being a lot of conversation on that next session, particularly as it relates to looming changes with a dental single administrator. So that was another thing that was up for consideration this last session, but didn't advance. So that kind of covers what happened in dental, what happened in broader healthcare that could impact what didn't happen. I meant to have a slide here on ongoing on current litigation. So I mentioned previously that there was a legislative change that would have or that would prohibit for-profit HMOs going forward. Obviously, the one in Minnesota currently operating in the PMAP program is United Healthcare. Obviously, they weren't very keen on being written out of the state system, and they have brought suit. The primary theory in court is, as many of you may have seen, the end of the legislative session was one of the more chaotic in my 15 years. And actually what ended up happening is they took about 11 bills that that hadn't quite got across the finish line, and they lumped them all into the conference committee report for the tax bill. They closed it, they brought it back to the floor of the House and Senate, and they voted on it with no debate, and frankly, no access to the actual bills for the members on the floor. Passed it in the final hour. Minnesota has a constitutional provision that requires two things. One, bills to be focused on a single subject. So even our omnibus bills have generally been categorized on a policy or budget area. And it also requires that the subject of the bill be in the title, kind of the paragraph list of statutory references on the beginning. The United Health lawsuit alleges that the bill passed in the final minutes of the legislative session is unconstitutional as it violates both of those provisions. The court has historically not struck down omnibus bills or other larger accumulations of legislative proposals under that statute. However, I don't know that they've ever been faced with one quite as all over the place as far as subject matter goes, and frankly, some issues in the bill title itself. So all of that goes to say a lot of things, including those dental health professional licensing pieces, were all rolled into this big package. And so there is some question if United Healthcare were to be successful, what that would mean for the totality of the bill, including a lot of the things we talked about today. All right, going forward, 2024 election preview, kind of three things to talk about here. First, as many of you may know, the Minnesota House of Representatives is up for election in November. All 134 seats are on the ballot, kind of setting aside the vacancies. There are currently 3 vacant seats due to resignations. Generally folks who weren't going to had announced their intention not to run again and then got a new job opportunity that necessitated them leaving the legislature early. But setting aside those, the House Democrats spent the last biennium with a 70 to 64 majority. There are 21 incumbents who either retired and one who were defeated in their primary. So the Republicans would need to flip 4 seats to take a majority. And I note that a 67-67 split is possible. It happened once, I believe, in the late 1970s. And then you have to have caucus leaders negotiate a power sharing arrangement, something where half the committee gavels go one place, half the committee gavels go to the other caucus, some split between the speaker and the majority leader who controls the floor agenda, those kinds of things. And I bring up the 67-67 note because, as I'll talk about in the next slide, there's a really weird possibility available here that I never would have imagined. The Senate is generally not on the ballot. However, there's one seat in which there's a special election on election day. Former Senator Kelly Morrison, after the legislative session, resigned to focus on her campaign for Congress. She's the Democratic nominee and anticipated to likely win a seat in the U.S. House of Representatives in the 3rd Congressional District. This is the seat currently represented by Dean Phillips. That resignation and that special election features a former state senator, Ann Stewart Johnson. She served 2 years in the Senate and then got redistricted in with Kelly Morrison. Kelly Morrison won that endorsement and eventually won the seat. So she former Senator Johnson Stewart is coming back and is running against a Republican named Kathleen Falk. So currently the Senate sits at 33-33 pending that special election, with the Democrats having had a 34-33 majority previously. So there's, it's rare that you have a single election in a single seat that would determine a majority that's isolated and not a part of a broader election, but that's what we have in the Minnesota Senate. And here's where things get particularly interesting. As I'm sure you all know, Minnesota's governor is the Democratic nominee for VP. And if Vice President Harris and Governor Walz were to win in November, there's multiple kind of trickle-down impacts in Minnesota. First, Lieutenant Governor Peggy Flanagan would be elevated to the office of governor, being the first Indigenous governor in the United States history. Then, most likely, again, things could potentially be adjusted if they were to have a resignation or something like that. But Senator Bobby Joe Champion of Minneapolis, the president of the Senate, would be elevated to lieutenant governor, making him the first Black lieutenant governor in state history. But if elevated to lieutenant governor, that would then take him out of the Senate, or frankly, any Democrat who was made president of the Senate, because it is possible that Senator Bobby Joe Champion could resign as president. The caucus could elect a new president, and then that person be elevated if there was somebody who was trying to retire and not, stay in the Senate or something like that, that they wanted to elevate instead. But whomever would be elevated, there would then be a special election in that person's seat. So again, say the Democrats win the special election, it's 34-33 until the president of the Senate replaces the lieutenant governor. You could start a session with a 33-33 split in the Senate pending a special election. Now, the special election will most likely be in a very safe Democratic district, but still, that is a situation where it's not impossible that we could start the legislative session with a 67-67 House and a 33-33 Senate pending a special, which means, well, actually, I have no idea what that means. That's unprecedented. That would be completely wild. It probably means not a whole lot gets done for the first 8 weeks or whatever of the legislative session pending that Senate special, but it would mean that the 2025 budget would probably be one of the more lights on, not a whole lot of substantive changes kind of situations, just because there's, it would force a level of compromise and negotiation that we generally haven't seen either called upon or be particularly successful in recent years. But obviously there's a lot of if this, then this, and if this, then that comes to this. However, I do think that that's kind of an interesting scenario that could have a lot of impact on organizations that are looking at more sweeping or substantive legislative changes. It also means that, one of the things we saw even with the Democratic trifecta this last biennium was that a one-vote Senate majority is very narrow to navigate. And so you do have a world where you could have a one-vote Senate majority and a one-vote House majority. Either way. And again, I think that really either Democrat controlled or Republican controlled in either chamber. And I think that makes it really interesting. It makes it a really difficult job for the leaders of those respective caucuses to hold everybody together and still try to have some kind of ambition in their policy setting agenda. And kind of the last thing I wanted to talk about is budget forecast. So this really, in addition to the election, the state's budget forecast is the biggest thing impacting the what might be feasible for dental providers or healthcare providers more broadly, or frankly, the legislature in its entirety next session. As I mentioned before, they started last session with a surplus in the current biennium and a projected deficit in the biennium we're about to go into. The surplus was greater than that projected deficit, so they would have enough money to get through the 4-year window. When they kind of closed up the deal, they left enough on the bottom line to cover what they saw as the forecasted deficit. So all that goes to say is I anticipate the November forecast showing a structural imbalance, but the state with enough money to still not be technically facing a deficit. And this was one of the war of words at the legislature is Democrats said there was a structural imbalance, but there was no deficit. Republicans took a different approach and argued that when you're projected to bring in less money than you're projected to spend, you have a deficit, regardless of whether you have cash reserves in the bank to cover that. Since the legislative session ended, tax receipts have been greater than forecasted, so it looks like there might be more short-term money on the bottom line to help cover things. But we don't really know and won't know until the end of November what Minnesota Management and Budget thinks is like those ongoing trends. Do they anticipate a continued structural imbalance, or are they projecting an economic scenario in which revenues catch back up to or exceed projected expenditures? I don't envy the folks at MMB because doing a budget forecast that relies on national economic modeling in light of and being called upon to do that 3 weeks after a presidential election with such disparate economic policies being discussed. The margin for error has got to be pretty significant there. But all of it goes to say that November forecast will give us a pretty good guideline as to what might be feasible. I think there'll be a lot of expectation management from whomever is in the majority after the November election to their caucuses saying, hey, there's only so much new spending or only so many tax cuts or only so many things we can do when you've got such a narrow margin on the forecast. But that will have a pretty big impact, particularly again, as I mentioned in the dental space, the legislature this will be their last legislative session before a potential single administrator contract is issued. What rates are needed to make that work, what other revenues are needed or resources are needed to make that work for providers. I think both the election as well as this forecast obviously have a real big impact on how that what tools are in the toolbox that the legislature looks potentially to have a bigger role in reimagining public programs, particularly dental public programs going forward. So the legislature convenes Tuesday, the 14th of January. That's a week later than customary. The legislature actually changed that law this last biennium, pushing it back a week. So it used to start the first Tuesday after the first Monday of the year. So oftentimes we're starting on the 2nd or 3rd of January. They bumped it back, and this year it has a greater impact. It's a budget year. They have to pass a budget bill by no later than the end of June to avoid a July 1st shutdown. Session ends in late May. Generally, in the first year of a biennium, they pass a budget. In the second year, they pass a capital investment or a bonding bill. However, they were unable to reach an agreement on one last year, so it's entirely possible that there's some conversation about physical infrastructure. That's worth noting in this context because a couple of years ago, for the first time in really state history, there was substantial money put into cash grants for capital infrastructure, allowing nonprofits to avail themselves of some of those funds in a way that were generally restricted to government state or local government owned buildings or infrastructure. Whether there will be sufficient resources to support those kinds of organizations or the political will to do something like that again remains to be seen. But it is something that is out there and may be a part of the overall spending conversation. It is the one bill that generally needs minority caucus votes because you need a supermajority in order to issue bonds. And so that's oftentimes the one piece of leverage that a minority caucus has to support other policy priorities in other spaces. And so it actually has become more common, I think, for those to be passed in budget years now when there's vehicles for other concessions or negotiations than in a non-budget year when maybe nothing has to get done. So I know that was a lot, but we still have some time. If folks have questions or if there is anything I could address that I didn't otherwise, I'll stop
Thank,
sharing my screen.
thank you so much, Matthew. I took a ton of notes, and this is the kind of discussion or information that I feel like I could just drink or eat because it's so helpful, and it's great for us, especially I would say those of us that aren't at the Capitol every day like you are during session, and you have such a rare experience that most of us will never have. I've got some things, but does anybody have a question or comment? We had a couple of comments in the chat about funding to support higher ed would be so helpful. And then also a comment about
Yeah, the one thing I might say about the higher, and this is something that I think a lot of folks have wrestled with before, is because there's a need, whether it's the dental association, whether it's the safety net critical access community, there are folks that for years have expressed a need and a desire to promote additional resources for the training of various health professionals, in particularly in the dental space. But the Minnesota State MnSCU system, the University of Minnesota system are big organizations with multifaceted leadership levels and strategic plans. And it's the legislature generally is disinclined to wade in and say, we want you to do this or we want you to do that. Oftentimes because they're usually already behind the need, right? It's usually there's a crisis shortage, and by the time you get those pipelines up, you're kind of always chasing the next industry. But we've seen this with the Minnesota state system in renewable energy technologies and training in those spaces, or I think we're seeing it in the health professional space as well. And it's just complicated for any industry or provider group to jump in and tell the University of Minnesota what they need to do and how that fits in. And so it's been one of those things that I think we've really wrestled with at the legislature, and that the legislature has wrestled with, because they will also realize that there's a pretty big, whether it's the head of the University of Minnesota or the head of Minnesota State, the chancellor, to manage all of these different demands and prioritize resources. I hope that as much as creating new task forces and councils is just more, meetings for folks like me to have to watch, the hope would be that there would be some recommendations on a new task force that could be institutionalized in a way to better connect the healthcare community and the dental community to our state's higher ed system. So.
And thank you for that. And I think for some of us, Jay Neubauer and I, we work closely with the MDA on some recruitment materials for dental assisting. And I think the thing that we always run into is, yeah, we can get more people to join the field, but are there spots available for them? Is there capacity within the education as well? So.
Well, and to that point, then it's tough. The legislature could say, sure, so here's the money we want to give insert higher ed organization to do more of this. But if it doesn't really fit into the strategic plan, if they aren't ready to receive it, if they don't have the physical building space, if they don't
Right.
it's really it's tough for the legislature to press its thumb on 20-year strategic plans for higher ed institutions as substantive as our public programs or our public institutions are. So,
Yeah. Yeah. Thank you
And
for that.
Matthew,
Yeah.
this is
There's a,
Jane Neubauer. I
oh,
live and work in West Central Minnesota, and Nancy and I work on multiple projects together. First of all, thanks for being here today. We really appreciate the updates from you. We have been looking very much forward to that. All of the things you've really talked about, and I know I'm kind of preaching to the choir here, but we we have such a huge shortage of providers in West Central Minnesota, particularly those that will accept Minnesota healthcare program insurances. We have providers that are willing and able to expand. They just can't hire and find enough staff. So, that education piece and the schooling part of it is really huge. Like Nancy said, we hope to expand programs in the school buildings as well, but also just keeping those program chairs full, making sure that, the folks enrolled in the programs can graduate. The testing that you talked about and some of the requirements there is a huge part of that too. So anyway, thanks again for being
yeah.
here. Thanks for all those updates. We love to give feedback from rural Minnesota. Our issues and challenges look a little bit different than they do in the metro parts of the state sometimes. So thanks for always keeping that consideration in the back of your mind too.
Thanks, Jane. And we have a couple questions in the chat. The first one is, how likely is the dental rate rebasing bill to pass? And again,
well,
we know that this is you just, you know,
well, I mean, there's a couple of, I mean, it
okay.
is really hard to prognosticate without knowing A, who's going to have the gavels, and B, what, if any, money they're going to have available, right? The rebasing has historically been talked about being done in a cost neutral way, with the first inflationary adjustment being in the third year. So what that means is they could do the rebasing and update the fee schedule cost neutral. So some things would go up and some things would go down, but the idea would be that it would be better aligned with what things actually cost to provide now than in the late 1980s, which is what the current fee schedule is derivative of. That could be done cost neutrally. The cost comes in the inflationary factor, which has been linked to that, which is what got it axed in 2023, was there wasn't any money in the tails. What the tails are what we call, so they do a 2-year budget, but the budget spreadsheets carry what it is in the next 2 years, and you have to balance that too. And so that was one of the problems. So that way you can't just kick out the costs and not have to account for them because the state's required to have a balanced budget. So it kind of depends on what the forecast shows as far as those economic trends and projected spending in the out biennium. So that makes it hard to handicap. I also think there would be reluctance from, frankly, everybody, the Department of Human Services, as well as the provider community, both, the safety net providers as well as the MDA, to see a cost neutral rebasing done without the inflationary factor, because it feels like that's kind of the hook that helps you get the other one. I mean, so I think there would be, because they could have done that 2 years ago and they didn't. So I wouldn't think they were likely to split it out this time around. So I mean, it's hard to estimate without those two big unknowns. But I would imagine it will be a part of well, I was going to say the governor's budget proposal. However, if there is a new governor, that's also hard to estimate. That being said, it'd be the same commissioner of the Department of Human Services, most likely. And that would, I think, be a consistent piece of where they're trying to go with the program.
Yeah, there's a lot of variables here.
Just a couple.
We have another question. What's the likelihood of legislation to modify the single dental administrator mandate?
I mean, again, a lot of that has to do with the election results. I mean, I think, if you see one or more of the chambers controlled by Republicans, there will be probably a greater desire to keep the managed care entities participating in the dental programs. I also think even if you have an extension of one-party control for another 2 years, I think there are legislators that I've been speaking with, including as recently as last night, that are like, okay, where is this going? Because it's now been a number of years since we kind of last weighed into that. We know this date is coming up, but we don't really know. Post the request for information that DHS had, and a lot of folks responded to last spring. It's kind of been silence, and so I think there's going to be some desire to either put some other parameters or specifications. I think it kind of depends on how the department presents to the legislature what it might be thinking. I also think that the concerns about the baseline Medicaid fee-for-service schedule and a bad economic forecast could result in maybe a delay or something like that. So I think the legislature will act on it in some way, whether it's, I don't think they're necessarily going to repeal the transition. They could delay it. They could put some parameters on it. They could, fund it robustly, and do some things to try to make it be successful. I don't really know, but I do anticipate it being something that gets committee time in both chambers, regardless of who's in control, as far as one of the things that the legislature knows it needs to discuss.
Great, thank you, Matthew. And Sarah Wolfcha had a question.
Yeah. Good morning, everybody, or good afternoon, and thank you so much for pulling this together. Really appreciate it. Matthew, I'm trying to understand what collective action we could take to increase training in Minnesota. My first choice would be dentists. And I'm just going to say, this is me personally, my clinic, and what we need. We need dentists, we need dental therapists, we need a hygienist, we need assistants. And when Jane said that, Central and Northwest, et cetera, Minnesota are short, everywhere is short. I'm posted continuously for a dentist, and I sort of feel like it's whack-a-mole. I hire one, and then another, one's going out to a pediatric specialty, or somebody's moving or whatever. And our dental school supplies not just Minnesota, but North Dakota. North Dakota doesn't have its own school of dentistry, so a significant percentage, come from North Dakota, go back to North Dakota. And it just I feel like this has been a perennial problem. I feel like we've been grappling with it for the last 25 years. And I've not ever seen one of those the dental school, for example, significantly increase. We have, thank goodness we've had the addition of dental therapy, but now we might be losing Metro State. So anyway, all that to say, is there anything meaningfully that we can do to really advocate for more training in Minnesota of dental clinicians of all kinds?
Yeah, Sarah, that's a great question, and it's like in a lot of the healthcare spaces. There is a a confluence of factors and causes to this, right? You have population growth, which creates additional needs. At the same time, you have a baby boomer retirement wave that is shrinking a lot of these workforces. Some of that goes. I had a colleague in a different space once who had the theory that the healthcare industry right now is a victim of a strong economy for the last 25 years, because healthcare was always seen as a safe place to go for a profession in a bad economy. You would go become a dental hygienist, you would go become a nurse, you would go to medical school or dental school or things like that. But in a strong economy and in a digital entrepreneurial world over the last 25 years, people have had other places to be more adventurous or do other things in their professional lives and haven't needed the state safety and security. The same argument is made about public school teachers, is that the shortages in RNs and school teachers and in dental hygienists is because the workforce that maybe historically would have looked to those industries has had other options. And so I think when it comes to trying to, address that, I think there really needs to be a high level of engagement between the providers, whether it's the professional associations, the MDA, the Dental Hygienists Association, the larger clinics, both public program, safety net folks, as well as the large private organizations, with the leaders, like the real leadership of the higher ed system. I mean, this has to be something that brings in the highest levels to prioritize those things and then develop what what is needed to create more seats in the program, and then what is needed to go out and recruit folks for that. I do think new Americans, first generation Americans are the, that same economic safety thing is what we've seen in some of the workforce trends there, but how do you get talented individuals into these programs? But I really think it has to be kind of at the highest level, because the legislature isn't particularly well equipped to cherry pick. Yep, we think this biennium we're going to build this program, or this biennium we're going to add more things there. They'll be the first to say we can just throw money at it, but if somebody's not prepared to take it, run with it, somebody's not desiring it, somebody's not buying that vision, it's really hard to make those to ramp up those programs. And so I mean, my general reaction there is this is a chancellor, president, head of the MDA, head of a couple of large provider organizations kinds of conversations, because I don't know that absent that level of buy-in, there's anything that the grassroots folks will be able to accomplish. And even if they were to get something passed out of the legislature, it still has to be done by those other folks. And so
Thanks for that, Matthew. Any follow-ups, Sarah? Are you? I'm good. Thank you so much. Anybody have anything else? We're nearing the end of our hour. I so appreciate this, Matthew. You've taught me so much over the years, and I feel like you can take really complex things that might really frustrate me that I maybe even don't want to hear about, but I need to know about, and you'll put them into language that really makes sense. And that is a gift, definitely. And we know you have the experience for, especially our membership at MOHC. So thank you very much.
always happy to be a resource.
Yeah, great. Wonderful. Thanks everybody for joining us. And yeah.
Thank you all.
Yeah, we'll see you soon. All right. Bye, folks.
Thanks, Al. Bye.
Thanks.